Okay, so welcome everybody to today's webinar. As I said to you, we're going to be talking about Lyme disease, and which is actually really rather topical at the moment. So it's quite ironic that this morning's headline in The Guardian, or one of the headlines in The Guardian, is actually related to the topic itself. So one of my next slide, I was going to be sort of showing you some stats on Lyme's disease throughout the UK. And the recent, or the previous estimates, sorry, were thought to be between about 2,000 and 3,000 annual sort of diagnosis of individuals with Lyme disease. But the headlines today seem to suggest that it could be as many as three times higher than that previously estimated, which actually doesn't really kind of surprise me that much in terms of when we think about, the symptoms and how difficult it is to actually diagnose Lyme's. And many people sort of, have so many different symptoms that they wouldn't necessarily associate with Lyme's, that it is really quite challenging to disease to sort of tackle and sort of identify. And so I'm hoping by the end of this webinar, if you're not familiar with the topic, then we hope that you will be slightly better educated, and not only just for yourself, but also to be able to sort of assist your clients as well. So the previous, as I said, stats seem to imply that around about 3,000 people in the England and Wales were diagnosed sort of with Lyme disease each year. Numbers, as I said, likely to be much higher than certainly is the case, it seems here. And the issue is not only it's about diagnosis, but it's about misdiagnosis as well. So many individuals with Lyme disease who maybe don't associate it with tick bites may be misdiagnosed with conditions such as CFS, fibromyalgia. Some of the early symptoms are very, very similar. And I grabbed all of this data out of the paper that was published in the BMJ today, and it kind of really shows throughout England, certainly, that the areas that are sort of more, or where you would be more at risk, are Scotland, southwest, and sort of down sort of Cornwall way as well. So they're the kind of areas that you should probably avoid going on holiday throughout the summer. The season of diagnosis appears to be throughout the sort of the months of June and August, which is not surprising really as well. So 50% of all diagnosis cases were within this sort of time frame throughout the year. So, I mean, this is something that I wasn't aware of before I sort of did a little bit more research as well. So we kind of talk about Lyme disease, and just to give you a bit of background as well before we sort of delve into it a little bit more as well. It's quite simply called Lyme disease because that's where it was first identified. So back 44 years, a group of arthritis patients living in Lyme, Connecticut, were diagnosed with Lyme disease. It wasn't until 3 years later that it was found to be tick-related, and then a further 3 years later, it was found that a particular bacterium, Borrelia, was identified as the main cause of Lyme disease. And obviously, there's been considerable research since. So this is a tick-borne bacteria, which requires both a invertebrate vector, so that's your tick, and your vertebrate host, so some sort of mammal. And this is obviously relevant to us because as humans, we can develop Lyme disease, but the host can be anything from a rat, a dog, deer, and so on. But Borrelia require both a vector and a host to be able to complete their life cycle. So whilst the disease itself originates from the tick bite, the symptoms that arise are primarily due to an inflammatory process, or unresolved inflammation, as we'll go on to sort of discuss a little bit more. And certainly, if Lyme isn't treated very early on, the infection can go on to affect multiple organ systems, primarily things like the skin, the joints, the nervous system, and the cardiovascular system. And then from there on, it's more kind of associated with sort of managing the sort of damage that has been done. So you can clear Lyme disease, but then you're sort of faced with all of the sort of like long-term damage to the nervous system, cardiovascular system, and so on. So incredibly challenging, not only to diagnose and clear, but then manage in a sort of like long-term approach. So ticks can be found generally anywhere where it is moist. They do not like to dry out. So typical habitats include things like woods, sort of grassy areas, campsites, gardens, you know, so if you're a rambler or, you know, you like to go on holiday and camp outside, or, you know, you've got a luscious garden, then sort of you need to be a little bit more aware of what's going on in terms of sort of, you know, how your legs and things are exposed and that kind of thing. At their most active between March and November, which fits into the sort of previous slide sort of diagnosis of sort of, I think, I can't remember what it was now, June and August, that's right. There is a risk of being bitten all year round, obviously. And the key issue, quite often the case, is that many people do not realize that they have been bitten. The bites are painless, and, you know, with these kind of sort of parasites, ticks, it is not in their interest for you to know that you have been bitten, because they have to kind of latch on and stay there for quite a considerable time. As my previous slide showed, it can be up to like 7 days as they're sort of feeding away. And again, there's sort of other increased risks. So if you've got a lot of animals around, so if you've got pets like dogs, cats, you know, then they can carry the ticks as well. So they can bring them in. So these are the kind of areas that we sort of look at in terms of, you know, exposure. Where do we get this exposure? So this is just a little slide to give you an indication of what this bacterium looks like. It's quite a unique one. So it's a spirochete, so it's spiral-shaped bacteria, and it travels around sort of using this sort of corkscrew sort of effective movement. So basically, as like, some of the papers that I was reading last week, some of them sort of imply that it uses this sort of corkscrew fashion sort of movement to be able to sort of outrun various sort of cells of the immune system like macrophage. So, and it also uses this corkscrew effect to be able to sort of burrow its way into sort of cells and tissues. And it primarily okay, so it evades the immune system for as long as it can. So it's sort of traveling around, and it needs to not be exposed to immune cells in order for it to be able to go intracellularly. And then that's kind of how it then sort of sits, and it sort of hides from immune cells. So the whole process is about evading immune attack for as long as possible. And this is a really sophisticated bacteria, because it has so many different host invasion strategies. For example, the first element of being able to sort of get into the system and stay in there is through the tick itself. So the tick will bite you, and it produces these proteins in its saliva that allow the bacteria to enter the host. And at that point, it exerts an immunosuppressive effect, which stops Borrelia from being sort of attacked by immune cells, allowing it to then freely enter the circulation. Then various sort of enzymes are released that sort of attract sort of blood flow to the area, allowing it to sort of have plenty of sort of food to feast on, as you were. Bacteria like Borrelia have outer surface proteins, but this bacteria has an amazing way of changing the proteins that it expresses on its cell surface. So depending on the stage of sort of invasion and sort of traveling through the body and traveling into cells, it changes the expression of these proteins. So it's completely confusing the immune system. It also produces a biofilm, so it sort of hides under or embeds itself within this sort of matrix of extracellular sort of substances that sort of form this sort of blanket around it, which completely hides it from immune cells, from antibiotics. And interestingly, this is a magnesium dependent process. So it uses up a lot of magnesium within the body, which has, you know, consequences down the line, which I'll talk about in a little bit more detail later on in the webinar. It also is able to enter stages where it just kind of goes dormant, goes very quiet, minimal growth. And this is really important because when we're considering antibiotic treatment, antibiotics will only work on a cell that is dividing. So it's almost like, you know, this bacteria is able to recognize when there is a danger, sort of, you know, red flag in the environment, and it just kind of shuts down, which is incredibly very clever of it, really, if you think about it. Once that little stress area is gone, or stress sort of response is gone, then the bacteria then starts to divide and grow again. It's also able to convert vitamin D into active vitamin D. And this has a process of shifting it from a T1 to a T2 response, which primarily improves its chance of survival. So there are so many ways that this Borrelia can outwit, if you like, the immune system to allow it to disseminate throughout the body and invade various tissues and organs, which is the sort of like later stages of the infection, with the more the symptoms are a lot more sort of amplified. So again, we'll go through those in a little while. And I mean, at some point there is an immune response which results in antibody production and cytokine production, but there's various sort of stages that are involved. The other thing that Borrelia can do is it changes its form. So it can exist as a spirochete, which is the little wormy thing that I showed you a little earlier, which is involved in sort of sort of moving throughout the body and getting into cells and tissues. But it's also able to form something called an L form. And this lacks a cell wall, which makes targeting by the immune system and antibiotics extremely difficult. It is capable of intracellular infection, and this is the form that converts vitamin D, shifting the immune response to a Th2. And then the cystic form. So again, this form results, as I said, it sort of, it sees this sort of red flag antibiotic coming into play, and it just sort of shuts down and becomes this little cyst. But what is important is that this form of Borrelia can actually lie dormant within tissues, such as the central nervous system, for example, for really long periods of time. And so quite often you can have a client who has absolutely no symptoms. Maybe they've taken a dose of antibiotics, they feel like, they're getting a little bit better, they feel like they're over it, cleared up from Lyme. And then at some point, when there's, maybe a stress-induced sort of period in their life, then the cystic form converts back to a spirochete, resulting in relapse. And this is why Lyme is so incredibly complicated to manage, because patients, clients who have Lyme can often have relapses. So, as I'm saying, you can feel, or they can feel that, they've made a good recovery, everything's okay, they've had the antibiotics, and then suddenly bang, something happens and the symptoms return. Okay, so what are the stages and what are the symptoms? What do we need to be sort of like looking out for, and what to, you know, not just for ourselves, for our own kind of knowledge, but for, you know, sharing this with people as well, you know, relatives, your clients, and so on. So, so you get your tick bite, and then within sort of 1 to 3 weeks, you get this acute phase. So this is the sort of primary localized sort of phase. Around 70% of Lyme patients will develop a particular rash, and it's called the classic bullseye rash. And it is, the reason that the rash occurs is it's a response. Enzymes are released, you get this sort of blood flow, and it's the blood flow that's sort of feeding the tick that actually is responsible for this sort of migrating red rash, which I'll show you in a moment. Not everybody gets this rash. Not everybody knows they've been bitten by a tick, but if this is something that sort of comes out, then it's really, really useful information, because it kind of implies that the rash itself is almost like a classic diagnosis for Lyme. Other symptoms include things like flu-like symptoms. So, I mean, these are a lot of the very early symptoms could actually be associated with just, you know, sort of, you know, we get a cold, we get what we tend to sort of call, oh, you know, I've had the flu or something like that. Or associated with a variety of other sort of health issues that we might be sort of diagnosed with or feeling or whatever. But the symptoms and severity are very different from person to person, and generally they can be really mild or they can be really quite severe. If there is a classic sort of known tick bite association, then, you know, most people, you know, if they're treated with a course of antibiotics, they can, the infection can clear up really quite easily. But the window of opportunity is very limited. You have to catch this within sort of, you know, the first few weeks or so. If the Lyme progresses, oh, right, okay, so just before I go on to that bit, so these are sort of classic bullseye rings that we get. So there's 3 examples here, and you can pretty much see yourself. So there's a big fat red dot in the middle, and then there's an area of sort of clearing, central clearing it's called, and then the sort of the circular red rash outside. And as I've said, if this is a rash that can be seen very clearly, it is almost sort of self-diagnosis Lyme disease. So not everybody gets the rash. Other people get different versions of the rash. So maybe, you know, if you're talking to a client and you're describing this and they say, well, no, I don't think it was a bullseye rash, but I do remember getting a, you know, a particular rash. You know, we've been walking, you know, been on holiday in Scotland or anything like that. So just because it's not necessarily sort of in tune or in line with this sort of classic bullseye doesn't necessarily mean that the rash should be dismissed. But that's the kind of thing that is sort of relatively classical anyway. So the chronic phase, so this progresses. So if Lyme progresses and if it's not treated early, the following weeks to months after an infection, the bacteria begin to enter cells, thus evading the immune system, and we start to see numerous other symptoms that are in addition to those, or can be in addition to those that are associated with the acute phase. And these include digestive issues, anything from sort of nausea, loss of appetite, some sort of element of IBS in some cases. We see mood changes, depression, fatigue, headaches, cognitive changes, so forgetfulness, anxiety, brain fog, and so on and so on and so on. So, but one of the sort of classic ones is this achiness and associated sort of joint pains, quite often in the knees and the large joints. And some of these patients, if Lyme isn't managed, will go on to develop symptoms of arthritis, so specifically Lyme arthritis. And then the later stage, or the last stage, is known as the autoimmune phase. Now, not everybody with Lyme disease will go on to sort of show these relatively, will go on to demonstrate these symptoms. So the long-term exposure may induce a chronic autoimmune disease, but not in everyone. And it's a result of the bacteria disseminating throughout the body, get into the brain, the central nervous system, the heart, the joints. The issues with the heart is actually really quite rare, I believe. And the issue seems to be associated with a sort of slowing of the heart, or the rate of the heart slows down. So these are incredibly serious when we consider the implications. Okay, but to sort of summarize really at this point, it's clear that the symptoms of Lyme disease are both numerous and diverse, and this makes sort of diagnosis extremely challenging, especially if there is no sort of classic rash at the beginning, early on in the sort of diagnosis process. So how do you diagnose Lyme disease? Okay, so it's a two-tier process, and this is the sort of classical taken from the NICE guidelines. As I've said, if you suspect Lyme disease and there is the presence of this classic bullseye rash, then the diagnosis is pretty self-explanatory, and we move straight into antibiotics. If there's no rash, but it is suspected Lyme, then we move to ELISA testing. Now, one of the other issues is that the diagnosis can be quite complex, because the antibodies against Lyme disease usually take a few weeks to develop. So tests performed before a couple of weeks can be negative, even if the person is infected. So we have to sort of take all of these things into account as well. The other thing to consider is that people who receive antibiotics early, within the first few weeks after a tick bite, may not develop antibodies, or may only develop them at levels that are too low to be detected. So the testing process tends to give rise to either sort of a lot of false positives, false negatives. But after ELISA testing, if this test comes out as positive, then we move on to immunoblock for IgG and IgM. But again, so a lot of people may test negative, but that doesn't necessarily mean that they don't have Lyme disease. So, but it is wise to sort of perform these tests anyway. The primary intervention for managing Lyme, certainly from a sort of pharmaceutical side, is antibiotics. And there was a nice meta-analysis published very recently this year that indicated that if caught early and people are given antibiotics at the appropriate time, antibiotics are extremely effective. However, as practitioners, we all know that there are generally always side effects associated with antibiotic use. And the issue with the antibiotics as well is that this is not a short-term treatment plan. A lot of the antibiotic interventions can be as much as 21 days, sorry. Quite often individuals will need one or two types of antibiotics as well to really sort of bang this one on the head. There are a number of treatment-related adverse effects, and we know that antibiotic use in themselves can give rise to sort of an array of various sort of side effects and issues as well. Antibiotics will only be active against the growing spirochetal form of Borrelia. So if this has progressed so that the bacteria has sort of shut down and become either cystic or L-form, or managed to be able to sort of hide itself underneath a biofilm, then the antibiotic is not going to be effective. And it's these persistiforms, so cystic, L-form, the biofilms, that are not killed by current Lyme antibiotics, are associated with these sort of persistent symptoms that occur in many Lyme patients, regardless of whether they've had antibiotics once or more. Here's a little picture of a little, here's your Borrelia sitting within its biofilm. So the biofilm prevents the bacteria from being recognized by immune cells, but it also limits antimicrobial penetration by antibiotics. So, okay, so symptoms. And this slide is really kind of giving you a list of all the kind of symptoms that are associated. And as you can see, they are numerous, very diverse. So these could be related to just about kind of any condition that we see coming into the clinic. But it's worth getting a really good, I mean, I think that one of the sort of takeaway messages from sort of this webinar is that when we are speaking and taking case history notes from clients, that the more information that we can get and the level of detail that we can get, the more information we get, the more likely we are to be able to sort of be able to help them, or certainly to be able to sort of identify, and you know, if you suspect Lyme, we can take appropriate action. And so one of the issues, again, as I said before, is that Lyme is often misdiagnosed. Certainly, you know, sort of considering sort of people going to see their doctors and sort of trying to get this sort of guidance and the help from there. And it's misdiagnosed anything through from sort of multiple sclerosis to gout, simple depression. I say simple, but it, you know, I didn't mean it quite as simply as that. But you know, some of the misdiagnosis that occurs can be quite frustrating for the client, certainly. But it just kind of shows the sort of diversity in the symptoms, and how this can lead to sort of getting the wrong treatment quite a lot of the time as well. Okay, so in addition to sort of taking really detailed case history notes, it's identifying red flags. So when your client is going into sort of detail about, you know, what they like to do, where they've been, you know, if they're sort of hobbies, holidays, where do they go? Do they go camping? Do they, you know, do they go walking in the hills of Scotland? You know, what type of clothing do they wear when they go out? Do they have pets? You know, getting details about symptoms as well, you know, because this is obviously quite a seasonal issue that we're sort of looking at here as well. And the rash as well, this is quite an important one as well. And it's, you know, if people have actually been bitten by a tick, not necessarily all ticks will have, or not all ticks lead to Lyme, as it were. But, you know, if somebody knows that they've been bitten by a tick at some point, this is really useful as well. And have they had multiple symptoms that don't respond to sort of conventional interventions? So there's a lot that we can gather when taking a case history. And just having the knowledge ourselves as practitioners can help us to sort of identify those red flags that we can then sort of work on afterwards. Right, okay, so from a kind of a symptom sort of approach, what kind of common factors do we see in a classic sort of like Lyme patient? Well, the first one, obviously, is that there is a potential for immune dysfunction. Now, this sounds pretty straightforward, but part of the issue with Lyme disease is that over a period of months, the immune response changes quite dramatically. So very early on in Lyme disease, there tends to be, or we tend to see a Th2 dominance. And this is this clever little bacteria going out of its way to stay hidden for as long as possible so that it can invade various cells and tissues. Once it's in there, the story kind of changes and we start to see more Th1 dominance. One thing that is, another thing, sorry, that is quite classical is that we see reduced levels of natural killer cells. So our natural killer cells are the sort of first line of defense against sort of bacteria, viruses, and so on and so on. And if you have reduced natural killer cells, then, you know, this is the perfect sort of environment for Borrelia to be able to exist and carry on. We also see a high Th17 activity and low trig. So we see a sort of a pro-inflammatory response, and certainly later on in the sort of autoimmune sort of stages of Lyme disease, this high Th17, low trig is really key. And the sort of symptom severity can be sort of, we see the symptoms tend to be a lot worse when we have low trig numbers, for example. So sort of increasing all of these areas, if we can kind of get an understanding of it, we can see where there are sort of points for nutritional intervention as well. But then the sort of classic ones, increased oxidative stress. We see increased inflammation, as a standalone, but also increased inflammation as a result of increased oxidative stress, and then again the other way around as well. So these two kind of coexist. One causes the other, and the other causes the other. But together, these cause upregulation of the kynurenine pathway. So we see our tryptophan metabolism sort of go away from serotonin production, for example. So we stop producing sort of neurotransmitters such as serotonin, melatonin, which give rise to these sort of side effects of not being able to sleep, feeling, you know, low mood and so on. Where we have increased oxidative stress and inflammation, we have compromised detoxification. Specifically to Lyme, this is really kind of related to low levels of glutathione. And the reason that we have low levels of glutathione are twofold. Partly it's because of the, you know, it gets depleted, high levels of oxidative stress, you knock out, or, you know, you deplete all of your endogenously made antioxidants. But also, Borrelia requires cysteine. So it kind of leaches the cysteine out of the diet, cysteine being the precursor to glutathione. So we get low levels of glutathione in individuals with Lyme disease. So again, this is a kind of an area for nutritional intervention. I spoke earlier about some of the sort of side effects, or not sorry, side effects, some of the symptoms were GI related. So not only do Lyme patients tend to have issues with digestive health, but if they've, you know, had their course of antibiotics or whatever, then we can sort of, that in itself is going to exacerbate it. And it's not uncommon for somebody with Lyme to have several courses and several rounds of antibiotics over several months, and sometimes over several years as well. If it's a really hardcore to treat, then it's not uncommon for Lyme disease individuals to have lots of rounds of antibiotics. Also, where we have low levels of glutathione, high levels of oxidative stress, etc., this in itself leads to mitochondrial dysfunction, which I'll go over a little bit later as well. And something else to sort of take into account as well is that some Lyme cases can sort of present with compromised nutrient status. So specific sort of vitamins and minerals, they can be quite low in and depleted. You know, the classic, as I've mentioned, is magnesium. But individuals, before they have been bitten, there are associations with low levels of vitamin E, vitamin A, for example. If you are nutrient compromised, if your stores aren't good, and if your immune system is a little bit sort of, you know, on the sort of dodgy side of things, then you are much higher risk of developing Lyme after a tick bite than if somebody is sort of, you know, nutrient dense, stores are up, you know, immune system sort of cracking nicely. Okay, so I spoke very briefly about natural killer cells, you know, and these guys are there to really limit the sort of dissemination of this bacteria. Numbers are known to be lower in Lyme patients compared to controls. They play a role in the generation of Th1 immune responses. So if you have low levels of nuclear factor, natural killer cells, sorry, what am I talking about? Natural killer cells. This tends to be related to this sort of presence of this Th2 bias. Yes, I did notice that earlier, didn't I? So I was talking about natural killer cells being associated with more severe and prolonged arthritis. So generally towards the sort of later stages, if you're dealing with people with sort of autoimmune arthritis, then sort of working on sort of increasing natural killer cells is one sort of point for intervention, increasing trig, down-regulating Th17, and so on. So, as I said, we see this kind of change in the immune function as this disease sort of progresses. So in early Lyme, it tends to be a Th2 bias. Later stage Lyme, it seems to flick back and become Th1 bias. Okay, so I've mentioned Th17 and trig as well. So again, this is about sort of points for intervention as well. If you can increase trig cells, you increase interleukin 10, which down-regulates your pro-inflammatory products. This is really kind of key in late stage Lyme. So again, points for sort of intervention, certainly in things like sort of arthritis resolution, because a lot of the inflammatory process that we see occurring in Lyme disease are not only inflammatory related, but they're actually related to a failure to resolve the inflammation. So it's about resolving inflammation. And this is where our little sort of family of omega-6 and omega-3 come in as well. So we see high levels of inflammation occurring in Lyme, certainly in the later stages, so with Lyme arthritis, et cetera, one thing that is known to occur in Lyme disease is this upregulation of phospholipase enzymes that are responsible for liberating arachidonic acid from our cell membranes, where it is free to be converted by various enzymes, so cyclooxygenase and LOX1, into pro-inflammatory downstream products. So again, so higher levels of arachidonic acid or low levels of omega-3 as well are often seen in Lyme. So arachidonic acid is free to produce things like TNF-alpha, leukotriene B4, and we also see higher levels of peroxidation products as well. Part of the reason for this is that in association with increased inflammation, we see higher levels of free radicals, and those free radicals will go off and they will cause lipid peroxidation of our long-chain fatty acids. So not just arachidonic acid, but also long-chain DHA as well. So pro-inflammatory products, increased levels of things like phospholipase enzymes, increased levels of peroxidation products are all associated with, certainly with sort of like later stage Lyme as well. And these are also associated with this failure to resolve inflammation. So, so sort of having a sort of understanding of the sort of omega-6 and omega-3 is really important here as well, because obviously our long chain omega-3 and omega-6, so we've got arachidonic acid, we've got our EPA and DHA, really important in regulating inflammation and regulating this sort of like end resolving phase of inflammation. And the enzymatic conversion results in the good guys. We have all the sort of downstream products that we want. The non-enzymatic conversion are the bad guys. These are the things that we don't want. And we can reduce this by increasing our antioxidant status or by increasing our ability to make antioxidants not enzymatically, endogenously. So things like glutathione, catalase, and so on. But we do see, so there's a couple of papers here as well that show that the levels of lipid peroxidation products is increased in Lyme disease. So we can start to see how all of these sort of begin to sort of come together. So we have increased inflammation and a lowering of inflammation resolution. So this is a kind of another point for intervention. So increased levels of cytokines, again, free radicals, etc., etc. Not only do they contribute to glutathione depletion, but they also start to activate our transcription factors, such as nuclear factor kappa B, which is then going to trigger more pro-inflammatory cytokines. And again, as I was saying, patients with persistent symptoms tend to move towards a higher Th1 activity as well. And this is where a lot of these sort of higher levels of inflammation also associated with very fatigue-related symptoms as well, which can be confusing. This is why a lot of Lyme patients tend to be misdiagnosed with things like chronic fatigue syndrome, ME, for many, many years before Lyme is diagnosed. And these pro-inflammatory cytokines, along with sort of stress response, so cortisol, etc., have the ability to upregulate the enzyme IDO. And the impact of IDO is we move away from tryptophan, away from serotonin, and we start to produce quinolinic acid. So again, evidence out there that shows us that individuals with Lyme disease tend to have higher levels of quinolinic acid. And the fact that their magnesium status is compromised means that there is no little gatekeeper sitting in the NMDA receptor. So magnesium usually acts to prevent overstimulation of NMDA. If you haven't got enough magnesium, then, you know, we have all of these sort of excitatory neurotransmitters that can then be free there to stimulate NMDA, and we get our sort of associated symptoms. So things like sleep disturbance, depression, libido is affected, etc., etc., etc. Okay, so many cases of Lyme disease, if we can sort of start sort of looking at how we can manipulate tryptophan so that it doesn't get converted through to quinolinic acid, if we can get our magnesium status up, etc., etc., we can start to sort of work on some of these sort of rather unpleasant symptoms that we see. Glutathione, mentioned it a couple of times. Glutathione peroxidase, as well as the level of vitamin E, is or has been demonstrated to be decreased by as much as 25% for glutathione and as much as 27% for vitamin E as well. So we know, again, this sort of like that there is higher levels of oxidative stress are contributing to the depletion of antioxidants in Lyme subjects. And then the final slide for this part of the webinar. Okay, so this is where we sort of start looking at how all of these add up to sort of start affecting our mitochondria. So we have reduced antioxidant status, glutathione, coenzyme Q10, really important for electron transport chain, that gets depleted as well. And increased oxidative stress lead to this sort of overwhelming opening of mitochondrial transport pores, which cause our mitochondria to sort of dysfunction and sort of shut down. I went into quite considerable detail in my CFS webinar a few months back. So if you're interested primarily more sort of on the sort of fatigue area, then that's a webinar that's worth watching. But again, so mitochondrial dysfunction is quite often observed in Lyme patients. So working on mitochondria, healthy mitochondria, is really, really important as well. Okay, so what do we do? So we've got all of these symptoms and we've got all of these pathways that are affected. What are the interventions that are in place? Certainly sort of from a pharmaceutical sort of side of it. NICE guidelines say that the first intervention should be antibiotics, and this is I mean, this is completely true as well. Anybody with Lyme's needs antibiotics. Antibiotics are the first intervention, and they can be very successful if the condition is caught early and the antibiotic is given at the appropriate time. After that, it's really about managing symptoms. So a lot of the sort of pharmaceutical interventions or prescriptions tend to be for things like painkillers, non-steroid anti-inflammatories, COX-2 inhibitors, and quite often antidepressants as well. Not primarily or per se for managing mood, but actually, serotonin, selective serotonin uptake inhibitors, et cetera, can actually be really kind of effective for sort of helping with sleep and things like that. So they're quite often prescribed for individuals with fibromyalgia with some success. But obviously there are sort of points for nutritional intervention there as well. Okay, so antibiotics. There are very common ones. There was a, paper that was published earlier this year, meta-analysis of antibiotics, which suggests that they are very successful, as I say, if you catch this quite right. But the intervention is generally a minimum of 21 days. So, and again, as I said, some people will need several rounds of antibiotics. For anybody who is taking any kind of vitamin minerals on the side, alongside antibiotics, you just need to be aware that there are a variety of contraindications as well. So there's kind of like this synergy between them, which is not a good one. So quite often they can decrease the absorption. So antibiotics decrease the absorption of the minerals and vice versa, et cetera, et cetera. So anybody who's sort of taking vitamins, minerals, anything like that, something like magnesium, which would be recommended, should take it at least 2 hours aside from their antibiotics. And also there are a number of antibiotics. I haven't listed them all, but just to sort of mention them all in one sort of foul swoop, really. Antibiotics can decrease the absorption or increase the elimination of other nutrients as well. So what we see quite often is that, individuals who are taking antibiotics obviously start to sort of possibly come through with some increased risk of sort of suboptimal levels of various vitamins and minerals. So if you know that somebody is taking a long-term antibiotic, you should really be recommending a good quality vitamin and mineral as well. On the side of sort of managing Lyme, we also need to sort of manage a lot of the potential issues that may arise as a consequence of taking sort of current treatments. So, I don't really kind of need to be sort of telling you in great detail about what those are, but we need to look at things like antibiotics, antidepressants, standard painkillers. If somebody's got various digestive disorders as well, we need to sort of be managing those as well. So it's taking these, on board as well as sort of like looking at Lyme itself. And this is a slide that I've used before in some of my other webinars. It's the sort of standard one of, a good quality probiotic is going to be really, really useful here. Making sure gut health is optimized is going to be incredibly useful for anybody with Lyme. I gave a webinar a little while ago as well on the benefits of taking probiotics and omega-3, not only for sort of healthy microbiome, but also for supporting immune function. And probiotics as well have been shown to enhance natural killer cell activities. If you could give probiotics, in combination of omega-3, we see this pattern of reducing Th17. We increase our trig numbers. We produce interleukin-10. MUC2 is one of the mucins that is involved in sort of keeping our cell adhesion on top. So lots of benefits from combining probiotics and omega-3 as well. And again, I covered this in a fairly recent webinar. So as I said, cysteine depletion is very common in Lyme. They require that for them to be able to complete their life cycle. Acetylcysteine is great intervention, actually, not only as a direct antioxidant capacity through being able to upregulate or produce more glutathione, but also acetylcysteine is a great biofilm disruptor as well. There's a good quality evidence out there for using NAC in Lyme. So if you can disrupt the old biofilm, you expose your bacteria, and then the immune system can get to work on it. The other sort of various nutrients that you can use alongside acetylcysteine include things like alpha lipoic acid, L-glutamine, which is good for gut function as well, vitamin C, vitamin E, etc., etc. Because as we know with any antioxidant, is that you can't really have one without the other, and you have to kind of support. So that it's this sort of cog effect. So they act together to sort of oxidize and reduce each other. As one's donating to reduce free radicals, then another one is going to be around there to sort of donate and keep this sort of cycle going. So good quality antioxidants are really key. And as you can see, my little cell membrane here, we have different antioxidants sitting in different areas of our cell membrane as well. So we've got vitamin C on the outside, it's water, looking after free radicals on the outside. Then you've got things like lycopene, which sits within the cell membrane. One of our favorites, if you've been with us before at any of our webinars, we mention astaxanthin every now and then. Astaxanthin is a great all-rounder because it spans the cell membrane. So it tackles free radicals on the outside of the cell, the inside of the cell, and within the cell membrane itself. So it's great. It's a great antioxidant. And then sort of looking at ways that we can increase NRF2. So this is a transcription factor that regulates the expression of our endogenously made antibiotics. I keep saying antibiotics on the tip of my tongue. Endogenously made, antioxidants as well. So glutathione, for example. Great one again is things like the polyphenols are great for upregulating NRF2. We've also got things like polyphenols, carotenoids, even omega-3, various sort of diets, things like, following Mediterranean diet has been shown to sort of increase our production of endogenously made antioxidants. So antioxidant support is really key here. And once we start to sort of increase our antioxidants, we reduce oxidative stress, which in turn reduces inflammation. So just to sort of go back to sort of a little bit of gut support, not just about probiotics and omega-3, but also things like L-glutamine. A great SIG-A booster is colostrum, bovine colostrum. And then obviously, we need vitamins A and D3. D3 is really important as well because, as I said, Borrelia often use that up to sort of shuttle our Th1 to a Th2. So we need to just be a little bit on top of vitamin D status as well. To boost natural killer cells, so I put beta-glucans at the top there. There has been some really nice evidence published over the last few years or so showing the benefits of beta-glucans for increasing natural killer cells. And then I've just kind of listed a number of other sort of nutrients as well that have also got natural killer cell activity as well, boosting natural killer cell as well. When it comes to reducing inflammation, it's like I put this slide in really because to sort of emphasize the importance of balancing omega-6 to omega-3 and primarily the AA to EPA ratio. So as I said earlier, phospholipase A2, COX-2 is overexpressed quite often. We see this in Lyme, and a lot of the sort of pharmaceutical interventions act on reducing the pro-inflammatory sort of properties of arachidonic acid. And we can actually do this nutritionally as well. So rather than sort of or relying we can limit the to EPA ratio in favor not only of low reducing, actually we can manipulate it into a more pro-resolving still aware sort of three sort of testing and maybe and the benefit sort of a paper discussed this by this into it at the bottom. A number of antibiotics, interventions, microbials, antioxidants, anti-inflammatories, and anything that is going to really kind of enhance the ability of the immune system to be able to respond. Mentioned biofilm disruptors, and again, this is really kind of important because a lot of the sort of persisting symptoms that we see in Lyme is associated with Borrelia being able to sort of hide underneath this biofilm. So feeding the sort of ability to be able to break down this biofilm is really key in sort of managing this sort of long-term sort of re-emergence of symptoms. Acetylcysteine is one of the best interventions. Then we've got probiotics. They've also been demonstrated. But a lot of the antimicrobial plants, so things like berberine, citrus seed extract, golden seal, for example, have all been shown to be beneficial for breaking down this biofilm matrix. And in fact, there are a lot of plants that are used that have anti-Borrelia efficacy. And they're anything from grapefruit extract, cat's claw. You may be familiar with some of these, or you may not. Some of them work specifically on various forms, so things like the spirochetes and the cysts. Others are more efficient on sort of biofilms and so on and so on. So quite often a sort of synergy, rather than just sort of focusing on one intervention, it can be important to include multiple interventions as well. So a bit of a mix and matching going on. And then sort of combining phytochemicals, which with micronutrients quite often as well, provides synergistic benefits as well. And again, I've included some papers here to sort of, if you're interested in sort of following this up and reading a little bit more. But there is evidence to suggest that, you know, combinations whilst individuals are using antibiotics can actually enhance the efficacy of antibiotics, which is really key because it's the antibiotics at the end of the day that are really crucial. Making sure that the antibiotics can get in and do their work is really, really important. Okay, so, and then targeting IDO. So we have all of these sort of array of symptoms that are associated with Lyme as a consequence of the sort of tryptophan kynurenine pathway, so sort of increasing quinolinic acid. So if we can inhibit or we can prevent or reduce the expression of IDO IDO, then we can switch over. So we can sort of push tryptophan away from this pathway and get it sort of producing serotonin. So we'll see improvements in things like sleep, and because we're producing more melatonin and so on and so on. So, improved sleep, libido, cognitive function, et cetera, et cetera. And there are a number of nutrients that have really good effects at down-regulating quinolinic acid production. Curcumin is one of the key ones. I'll pop that at the top. And again, EPA, out of the omega-3s, EPA and DHA, EPA seems to be more effective at reducing IDO, and cortisol. Cortisol is also an IDO inducer as well. And actually, the EPA IDO relationship fits really, really well with studies that show that EPA used for sort of managing symptoms associated with mood disorders fits really, really well there as well. Butyrate. So if we can increase our short-chain fatty acid producing flora, we increase butyrate, or you can, interventions with sodium butyrate are also quite effective as well. But the whole kind of like, right, let's just look at inflammation. So increasing antioxidants and sort of supporting our own endogenously made antioxidants is in itself going to reduce inflammation. So we're going to get reduced cytokines, interleukin 6, interleukin 1, TNF-alpha, et cetera, that are known to upregulate IDO. So this kind of like multiple sort of synergistic interventions that are all going to be sort of helping. So reducing anti-inflammatories, increasing antioxidant status, et cetera, et cetera. One of the sort of key areas, or one of the key symptoms with a lot of people with Lyme, is this sort of overwhelming fatigue as well. So supporting energy is really crucial. And it's the same kind of intervention that we see for CFS, for fibromyalgia, et cetera, et cetera. We know with Lyme specifically that there is a depletion of magnesium. If you don't have magnesium, you don't have a cofactor for ATP. ATP is not functional unless it's holding hands with magnesium. So we need to make sure that our magnesium status is on par. And just sort of increasing magnesium can have significant improvements actually in terms of sort of energy, just through its ability to help produce ATP. And again, another one, so CoQ10, ubiquinol, really important as an antioxidant. So if we're depleting that, it's also vital for electron transfer as well. So if we have low CoQ10 status, then we're going to have reduced ATP production, and we're also going to have higher levels of oxidative stress. And again, studies are showing that CoQ10 helps to sort of protect from the damaging effects of oxidative damage, and then sort of this reduces the actions of IDO in terms of chiurenin and quinolinic acid production, etc. And another kind of area that we need to look at, in terms of sort of supporting energy, I mean, just to sort of go back a step there, magnesium isn't just required for ATP, it's required for so many different other enzymes that are involved in sort of energy production as well. So it's not just about ATP, it's about supporting other sort of aspects of energy production as well. But when we think about sort of production of acetyl coenzyme A, for example, which we need to feed into our citric acid cycle before we can then sort of enter into this electron transport chain, if you're not producing acetyl CoA, then you are not going to have anything to sort of work with down the line. And a number of vitamins and minerals are required. So specifically in terms of CoA, we're looking at sort of B-bits, thiamine, niacin, riboflavin, pantothenic acid, and so on and so on. Other interventions that you could consider are things like D-ribose, obviously as a sort of direct sort of precursor or building block for ATP. Acetyl cysteine comes up again. Lipoic acid, L-carnitine, obviously helping sort of beta oxidation of fatty acids, etc. So there's multiple nutrients that we can consider for sort of boosting and supporting energy. In terms of sort of vitamins and minerals, we generally kind of consider or make recommendations for either a methylated B complex or a multivitamin and mineral. If you're thinking of advising a client to take vitamins and minerals, we would probably recommend the multivitamin and mineral over a B complex because of all the other kind of nutrients that are required. So zinc is a really big one as well in Lyme. Vitamins A, E, C, D, etc. Go through the alphabet of my multivitamins and minerals, but probably more comprehensive than a standalone B complex in this case. If you're interested and you want to have a little bit more information about the multiple sort of products that we produce that you might want to consider for sort of recommending in sort of Lyme's cases, then this is our multivitamin and mineral. All of the information is obtainable on our website. As you can see, you know, we prioritize the sort of most effective, most bioavailable forms. The vitamins, the B vits that we use in our multivitamin and minerals are exactly the same form as you see in our Super B complex. So, you know, we use body ready folate, so we reduced folate, we use riboflavin 5-phosphate, so everything that is set up and ready to go as soon as you've kind of consumed it. So these are the most effective of our sort of vitamins and minerals from our range. Can't recommend magnesium enough, certainly for Lyme's individuals. And again, you know, if you've been to our webinars before, you might be familiar with our magnesium, but it's really to highlight that not all magnesium supplements are the same. We target multiple uptake areas by using a triple magnesium blend. All of our magnesiums are fully reacted. And that means that you don't get any hidden magnesium oxide. So magnesium oxide is the form of magnesium that just kind of goes through you. You don't absorb it. With nutrients, it's not about what you're taking and how much you're taking, but it's about how much is getting into your body and how much you are retaining in your body. Because if it's not in the body, it's not going to be working. So this is our triple magnesium complex. Moving on to I mentioned astaxanthin before, so if you're looking for a great antioxidant support, again, can't recommend this product enough to you. It's certainly great for reducing reducing oxidative stress, boosting antioxidant status. And curcumin, our optimized curcumin. So this is great for reducing oxidative stress, increasing in endogenously made antioxidants as well. So it upregulates glutathione. It sort of stops nuclear factor kappa B from going crazy, producing far too many pro-inflammatory cytokines, etc., etc. So as an anti-inflammatory, and certainly in terms of, there was a really nice study published fairly recently talking about long vida curcumin for joints, for reducing inflammation. So anybody who's got sort of like long-term and they're having joint issues, then curcumin is a great anti-inflammatory. There's a lot of clinical evidence behind curcumin. And again, it's about delivery. So long vida keeps curcumin in free form. And if it's in free form, it can't be excreted from the body. So it sits there and it can kind of get on with the business. So again, this is a great product. And then energy support, we recommend obviously sorbiubiquinol. Again, we sort of look at delivery. You know, CoQ10 is one of those sort of nutrients that really it's really not very bioavailable at all. So what you do actually manage to absorb, again, probably tends to get excreted. So with all of our interventions, we look at delivery, we look at how that delivery, bioavailability, and retention as well. So our Vesisorb delivered CoQ10 is really highly effective, really, really good for helping with energy issues. And again, restore and maintain. So we always recommend sort of starting off with EPA, get your AA to EPA ratio balanced out, get inflammation under control. But what is really important is that you do not want to displace arachidonic acid too much, because whilst it tends to be kind of labeled as the bad boy of the omega-6, it actually plays a really important role in switching from pro-inflammatory to resolving inflammation. So after maybe 3 to 6 months of pure EPA, we then move on to introducing EPA with DHA, a little bit of GLA there as well to support healthy levels of arachidonic acid. If you're not sure, it's worth testing, because you need to make sure that your omega-3s and omega-6 are in balance, especially your AA to EPA ratio is really crucial. And also it's really useful because then you know how much to recommend as well. Make sure your levels are at therapeutic levels. So really it's, I hope this webinar has been useful for you to really kind of put it into sort of a summary. If you're seeing somebody and you're getting all of these red flags, but you know they've not mentioned Lyme, you've not mentioned Lyme, but you know everything that you're kind of getting from them makes you suspect that there is Lyme, you know, deep dive a little bit more with the questioning. If you do think Lyme is involved, then it's worth getting them to just visit their GP, because or working alongside GPs as well. You can do private Lyme testing, but you know if the GP is going to do it for free, then you know get them to do it. Work with them because they will need antibiotics. If you can get them on to antibiotics, then they do stand a slightly better chance of sort of recovery. But it's going to be a bit of a long haul as well, or it could be a long haul. So we're looking at, you know, maintaining good gut function, doing everything that we can to support immune, good healthy immune function. So, you know, increasing natural killer cells, making sure that we've got good Th17 trig balancing, etc., etc. Make sure that we've got healthy tryptophan, kynurenine signaling. We need to be supporting detoxification, and probably most importantly, we need to be looking at how we manipulate inflammatory response, encouraging pro-resolving processes, managing oxidative stress. Okay, so, and on that note, I will just do a final call out. I don't know whether anybody's got any interesting questions. I think my colleague Danielle is answering all the questions. So if anybody does have anything that they want to ask, I'd be very happy to take emails later today. We'll have the slides made accessible for you, probably within a couple of days. And